Okay, let's get started with some updates on stats in Palm Beach County. And if you could put this on the board. The first slide, we're talking about the first slide you've already seen. It's 21 and 22. Just to recap, we reduced our opioid overdose death rate 14% in numbers. And then in 22 over 21, 19%. Let's go to the next slide because that gives us our current numbers through October 15th from the medical examiner's office. The snapshot back in 22 was 441 total overdose cases to date with outstanding cases. And the deaths were 333 at this point, slightly more than the 3/4 mark. And 76% of the total OD cases were opioid. Fentanyl was present in 92% of the cases. Now this year, through, this says 8/21, but it's 10/15. I'm sorry for the typo. So it's January through 10/15. There are 125 cases, so this is a snapshot. Total drug overdose cases 431, which is slightly down from last year, but with all those cases outstanding, we won't know for sure whether we're below, above, or at the rate we were at last year. The total opioid overdose deaths 294, again with 125 cases pending. That's a tick down to 68% of total overdose death cases processed by the medical examiner. Fentanyl was at 94%, or is at 94% so far. So it's up a couple of percentage points from 2022. Now we do expect in late November, or last year it was early December, first week in December, the 2022 numbers from the FDLE statewide medical examiners offices. So we'll be for sure talking about that at the next meeting in January. Xylazine so far this year from 22 to 20, again, another typo, 22, 23. Oh, actually, I'm sorry, 22. We had 24 xylazine overdose deaths. We're down a tick right now to 16 this year, but again, a lot of outstanding cases, so we'll know better at the next meeting when we'll have the final numbers. NPE, which is 20 times more potent than fentanyl. Not quite as bad as carfentanil, but death in for sure. 22 we had 9. 23 we have had 0 so far this year, so that's encouraging. Fluorofentanyl, we had 87 and 22 so far this year, 45. So look forward to the complete numbers that'll be at the next meeting on January 4th. Go ahead, the next slide. And when I say complete numbers in January, we'll have the numbers, but there'll still be outstanding cases. We won't have complete numbers for 23 until probably sometime in April or May. Good news continues in terms of transports. There's been a reduction of transports of 15% to date. So that's January 1st. Again, this is a typo. It should be January 1st to September 30th. No, yeah, September 30th, I'm sorry. And so far we're 15% down from last year, which again, you know, take it for what it's worth, but the opioid transports are down. And this reflects only Palm Beach County Fire Rescue, which is approximately 50% of the county fire rescue. But it gives us a good indication of how we're doing countywide. Okay, next up, we don't have this on your agenda, but we're going to have the new numbers, the updated numbers from FAR. And if we can put those up now.
I think Heidi's going to share her screen.
Heidi, you're going to share your screen? Okay. And my hat's off. FAR has already a national reputation, but it's growing even greater due to the changes that have been done in the last 6 months. and the numbers of beds. But go ahead, Heidi, I'm not going to steal your thunder. Tell us what's going on.
Thank you. Thank you so much for that. I appreciate that. We all appreciate that. We've been working very hard. Okay, so yes, and hello, everybody. Our statewide bed count right now is 8,729. That's up 10% since January of this year, which is super exciting. We have 1,793 statewide units. Level 1, 2, and 3 beds, we have 1,026 units, 5,619 beds. Level 4, we have 766 units and 3,102 beds. The next section gives you a snapshot of what we're doing per county. I can go through this line by line or.
No, that's okay. Everybody has this. I should have gotten this in their email.
Right.
So they can take a look at it at leisure.
So in running totals for the state capacity trend, this is exciting news. In 2017, we had 3,280 beds. Like I said, right now we're up to 8,729 beds across the state. That's expanding. We have probably at least a dozen applications in process right now. We are working very hard at providing training for our providers to get and encourage them to become MAT providers. So we're trying to increase our capacity for MAT beds. Palm Beach County numbers, we have 95 certified providers, 766 units, 3,477 beds. Out of those, 1,536 are for men and 599 are for women. And we have both male and female programs. 1,314 beds. Palm Beach County has 28 LGBTQ beds. We're working towards expanding that as well. So we have 7 programs that are level 1. That's 30 units, 100 beds. Level 2 is 66 programs, 313 units, 1,720 beds. Level 3, 5 programs, 37 units, 124 beds. And level 4, 40 programs, 387 units, 1,533 beds. Our overdose numbers from July to October, 15% death rate. So we have a total of 20. Out of the 20, 19 of them were male, 1 female, 3 deaths. Our city report, Bradenton, we had 1, Boynton Beach 1, Delray 6, Fort Lauderdale 3, Lake Worth we had 1, Lantana 1, Pompano Beach there was 4 with 1 death. Lantana had 1 death too. I'm sorry I missed that. Vero Beach 1 overdose, St. Petersburg 1 overdose, in Tampa 1 overdose. This I'm not going to go through everything line by line in the interest of time, but this gives you a breakdown of the age report, the drug preferences. You can see 17 of the out of 20 drug preferences were fentanyl. So that's still, it's very scary. And with that, I will stop sharing.
Okay. By the way, that's astounding that there are so few overdoses for 8,700 plus beds in the state of Florida. Now, I understand that there may be overdoses that slip through that aren't reported because they're reversed without calling fire rescue. But I believe that it's mandatory for any certified recovery residents, whether there's a transport or not, that it's mandatory that they be reported.
That is correct. They're required to report any type of an incident that involves law enforcement, EMS, anything like that. So if there is something that slipped through the cracks that you have heard of, please let us know so that we can follow up and make sure our providers are fully aware that they do need to report those incidences.
Okay, that goes for everybody who's tuned into the meeting.
Yes.
FAR is very aggressive is the wrong word. I think vibrant.
Proactive.
Proactive. That's good. In their enforcement of the rules. They take complaints seriously. So feel free. I mean, but again, out of all the statistics that you've talked about, that to me is the most promising one of all is there are so few overdoses in FAR certified homes across the state. That's awesome. Did you have anything more you wanted to add, Heidi?
At the moment, I think I'm good. Does anybody have any questions?
Any questions or comments? Seeing no hands, let's move on to Oxford House. By the way, in 2017, there were no Oxford houses in Palm Beach County. And I don't think the first one was opened up before 2019. Michael, you can correct me if I'm wrong there, but what's going on with Oxford House? Do you want to share the screen, or do we have a copy?
He's gonna share it.
Okay, you're going to share? All right.
Mhm.
Yeah, unmute yourself, Michael. Can't hear you. Still can't hear you, Michael.
Can you hear me now?
I can hear you now.
Awesome.
Was that the old school Verizon ads? Can you hear me now?
Yeah, so March of 2019 is when we opened the first house in Palm Beach
Okay.
County.
Good to know.
Yeah. Yeah, so Oxford House in Florida, it seems to be going pretty well. Currently, we're at 154 houses across the state with 1,410 beds, including 97 men's houses, 25 women's houses, 29 women and children's houses, and 3 men and children's houses. And all 3 of those are new. We converted a couple regular men's houses to men and children's houses, and we opened up a brand new one. Continuing to expand, we've opened up houses in some new cities over the past couple months: Palm Bay, Sanford, and Crestview. And then we got some houses coming online soon in some more new areas that we're excited about. We've had 1 overdose, and it was a fatality in the Cape Coral area back in September. And so overall, Oxford houses in Florida seem to be doing extremely well. We're continuing to really work with our model and work with our residents on training appropriately within our model. We're continuing to do in-house training, training at the chapter level, which is all of the houses in a local area. And then we're really kind of vamping up to do regional trainings, just something we've done periodically in the past, and we've done it on the state level, and we're going to continue doing it on the state level, but we're going to be doing more of these regional trainings with a few of the areas coming together, just to really try to hone in on certain things within the Oxford House model to make sure that we're following everything that is outlaid in that. And so those seem to be going well so far. We sent a bunch of our members to our Oxford House World Convention, where they got to experience a bunch of very cool and interactive things and really get to hear some experience, strength, and hope from past members and people within the recovery space. It's a very beautiful experience. Yeah, I mean, overall, with 1,400 beds, that's a pretty good amount of growth for us over the past 4.5 years. We definitely plan on expanding from that and continuing to meet the need that is ever prevalent in the state of Florida, and really do it in a way that we're maintaining quality. We have our upcoming state workshop in March, and then our World Convention in Orlando in 2024. We definitely would like to get anybody that is part of this to come and check out what Oxford House is all about. And so if you're interested in that, please reach out to myself or Lori. These are our contact. And so, yeah, it's overall, Oxford House in the state of Florida could not be going better from my perspective. There's always going to be issues and things, but my staff and I do a very good job at mitigating those things, and things seem to be going rather well.
Thank you, Michael. And one thing to note, between FAR and Oxford, we are over 10,000 beds in the state of Florida. So that's pretty cool. Don't think there's any state that comes anywhere near close to that. Okay, I'm going to move the agenda a little bit here because I think we're going to have a brief presentation from Dr. Andriek on an update on the addiction stabilization unit. Dr. Andriek, you have anything you want to share screen-wise, or do you just want to wing it?
Yes. Hi, good afternoon, everyone. Let me share the screen, and I'm operating not in my office, so please be patient with me. I'm trying the best to find what I want to show. Yes. Can you guys see my screen?
Yep.
Okay, so this is what I regularly provide you for addiction stabilization unit update. This is as far as last Monday. But first, I wanted to share that there is overall concern in the community that ASU is closed. That's kind of like common comments that I get recently. And I think the short answer, ASU is not closed, but some changes were implemented in the way how they operate. That kind of, an ASU, as a reminder, is a JFK North campus. It's not healthcare district operating unit. We just call the whole system of care in JFK North campus as ASU. We kind of generalize that, but technically there are two components, ASU and a clinic, that are on that campus. So JFK North CEO recently implemented that length of stay of those patients is a little bit shortened, and ASU does not have a designated area for substance use disorder patients only. So now technically the biggest change is that a whole ER function as any bed can be substance use disorder bed. However, the patient continued to receive the same treatment. I'm going to repeat that. There is no change in treatment. Suboxone is offered, and actually high-dose Suboxone, what is the most recent evidence-based practice that not many ER is implemented nationwide because protocol is not as simple as regular Suboxone inductions is offered in this ER. And they're connected to the recovery coaches. However, patients who come during regular hours, who are walking in, and 80% of those patients are walking patients, they're connected with our recovery coach even before they're put in ER. That's the reason why on this slide I'm sharing, you can see drop in those patients, because this is really data. I'm sorry. This is a data for the part of, I lost it, sorry. This is the part of data that is admitted to ER and then connected to our recovery coach. So that's why a little bit is skewed here on this slide. But you can see that we still have around 100 patients, more or less, that are connected directly from ER to our recovery coach. We have recovery coach in waiting room, so that's why many of them are intercepted by the recovery coach and won't hand off to the regular clinic. But because of the community concerns, Ashley Ventura told me last week during the meeting that we have regarding those concerns, that her communication department is issuing statements regarding this. So I'm anticipating any day that JFK will issue a statement describing this, what I just shared with you, and that those are her descriptions to me, and that's going to be in their formal statement. On the clinical side, we didn't change much. Not at all. We have more patients than ever. We're averaging around 10 intakes a day. That's, again, on JFK campus, building A, medical building A, where our clinic is. And this data here is only from ASU, but down this deck that I shared after those meetings, sometimes in advance. I apologize, I didn't share today, but I can share with Mary after the meeting. Gives more details about actual clinic data. That's here. You can see, you continue to see our demographics, number of patients, as well as number of people who we consider new intake, return visits, as well as uncontrolled discharges, as well as the reasons for uncontrolled discharge, as well as data of self-reporting overdoses, what coincides with overall trend as Al reported, that we have less overdoses reported by patients as well compared to some previous periods. But most important part, as always, of my clinic side data is the long-term measurements of BAM indicators, brief addiction monitoring, that we use to measure the long-term outcomes. And this is summary of all patients that we carry under the care. The bottom numbers of 3, 5, 7, 9, etc. indicates number of months that are under our care. And this is what we want to see, that average use scores during the time go down, average risk scores during the time goes down, and average protective scores goes up. That kind of completes overall a presentation about ASU. I'm gonna, as I said, I can share this with Mary to distribute to you. I'm just gonna use a PowerPoint format instead of this automatic daily report that I got, weekly report that I get every Monday. But I would like to share with you another updates that I have, and I'm going to be open for questions. Let me just go back to share my screen. What is related to last month, we opened our, same way how we have Mangonia Clinic on the north, we opened our Delray Clinic down south. Some of you were present during the opening ceremony, official ribbon cutting ceremony. But for those of you who were not able to attend, I wanted to share a couple pictures. I also shared with Mary flyer that I would like that she emailed to all of you, so you can kind of share to your partners and clients if you wish. It's a one-page summary that actually describes services that we have in this location and can be easily distributed to everybody who needs to refer patients. But bottom line is, this new clinic location on Congress Avenue that is just across the old health department building, this is the entrance of the building, serves as one-stop shop, not only for substance use disorder, but any primary care and dental care and psychiatric care of anybody who lives in the community who is underinsured or non-insured. So technically, Dr. Moran, even your patient that you discharged from your care, and now they need long-term psychiatric care, and they don't have means or ways or insurance to do that long-term, you can refer them here. They can establish care with our psychiatrist in this location.
That's great.
So, but as well as primary care and women care, and as well as dental care. So I'm going to go through a couple slides, how it looks. This is our team during the opening ceremony. I just wanted to kind of, and I can share this slide deck if that's kind of helpful for people to see where they're going, if you think that's helpful. But those are just a couple of slides. It's we really renovated that space with one-stop shop in mind. So this is how typical exam room looks like. This is our pharmacy on site. This is where all primary care medications can be filled, as well as daily Suboxone or weekly Suboxone, as well as all psychiatric medications. We don't have still injectable psych medications, but we are working on that. We should have it shortly. This is some of our office space. This is our dental clinic. We have 8 dental chairs and 2 dental hygienist chairs on the same location. This is our group room with GBAD group behavioral addiction therapy groups are happening, equivalent to Mangonia. This really empowers us that in a one-stop shop manner, we can provide a care for more patients at the same time. This is just some slides from the opening ceremonies. This is our waiting rooms, breaks rooms. This is actually separate entrance for substance use disorder. Part of the clinic we have, it's the same shared space, but we have 2 different entrances because sometimes during the group a lot of people come in the same time, so we open separate entrance for substance use disorder. We also anticipate that police will in the future drop off here, so we wanted to kind of have more access, kind of separate access for them. Again, this is registration of substance use disorder space and shared space for licensed social workers and psychiatrists on that mental health side. This is vital signs station, and this is another detail from our group room. And that kind of completes the slide deck about how the new clinics looks like. But I don't know if Ariana made it to this call. I see that she's supposed to be late, but this is something that she asked for the longest time, right? That's all fine that you have Mangonia Clinic, this comprehensive type of services in North, but what's going on with the South? So we now have on the South as well And I wanted to share this with this group. And I'll stop here. I know I talk a lot, but I'm open for question now.
Any questions? Any hands?
Alex, Jeff, I have a question.
Yeah.
I raised my hand. Here, wait, let me raise my hand. There, I raised my
Okay,
hand.
there you go. Jeffrey Lynn.
Oh,
raise
sorry, my
your hand.
video's up. Sorry, my video's up.
Follow the rules, man. Follow the rules.
Sorry. No, I'm trying to find the buttons. Hi, Dr. Andrick. It's more of a statement than a question. And I'm speaking unofficially, but on behalf of FAR, because I attend their meetings and people from FAR on the call. It's come to FAR's attention, just trying to coordinate that. I'll say we don't fully understand and want to meet with you guys at the healthcare district, like virtually, to understand your process from the point when you, for lack of a better word, discharge someone, because there's some, I think, questions or concerns or confusion on our end, on FAR's end, over what's happening to those patients once they leave and where they're being placed. Because I think there's also there are some questions posed to us on FAR on the appropriate placement for people that leave the ASU, like the level of housing that they should be directed to. So I just think we need to understand more. We don't have to do that now. I just want to plant that seed. Unless you want to, I don't want to take up the time from the legislature.
Yeah, no, and that's a good question. So there is no discharging here, right? Patients from ASU, and in that slide that I shared, 60 to 65% of the 70% of the patients discharged from the ASU reach out the clinic, right? So you're warm handoffing them. We have those peer counselors or recovery coaches, we call them, right? They are 8 to 10 hours physically in the ER, but then after hours, we have 24/7 answering service that they're connected to the recovery coach. Those patients are warm handoff to the clinic that is outpatient. Many of those people, 65% of the patients who reach the clinic, either through ASU, but majority of the patients walk to the clinic on their own, are homeless of some kind. It's not only the street homeless, it's also doubling up that we count and shelters as well. Like 65% fits some of the category for the homeless. We work closely with them to find those beds, but bad in our mind is not bad that is necessarily in your bed, that is kind of recovery bed in a sober house or in a traditional inpatient 30 days, 60 days, 90 days stay. Bed can be Lewis Center bed, right? They're homeless people, but they receive very intensive treatment with us during the day. We're outpatient-based program. So some we are able to put in a Uptide, or we are able to put in a Vicar House or Lewis Center or DAF, but they continue to come to us to outpatient once they discharge from DAF or in their Lewis Center that doesn't have treatment facility. So for us, bed means place to sleep, not necessarily bed where you receive and place where you receive all your treatment, because they come to us to outpatient treatment. Not everybody can receive inpatient treatment, neither is ASAM indicated, right? You have to, some people are best that they live normal independent life and continue to receive treatment as outpatient. So our place, our bed is different, what we consider bad, what you consider bad, but many do reach out what you consider bad.
Jeff, let me interject here, because we're going to have a greater discussion of this when we talk about the legislation with the MAT proposal. And we are talking about not only recovery residence beds, but respite beds, and inpatient, perhaps. There aren't many of those around. But we will have, let's resume this discussion about what we do with people who go through the clinic and have needs where FAR may not be able to meet those needs. So we'll continue that. I did have one other question for you, Belma. When somebody has an issue after hours, okay, and I'm not talking about an overdose that goes to the hospital, but somebody needs support at that, do you have a hotline, or you just work regular hours and you know,
So we have a 24-hour, 24/7 answering service.
okay,
And for all medical needs, so after 5 and on weekends, the clinics are not open. Through answering service, you can reach our physicians who either address your, sometimes, you know, you need medication, you have a question about your medication, and that's covered with our regular doctors. For last 9 months, we added a line for that answering service to transfer to recovery coach as well for substance use disorder patient needs. So
okay,
for them, you have a special extension. If you call after hours, 642-1000 number. And by the way, that number is our main number that is in that flyer. I asked Mary to email this group just before this meeting started. That's the, and you follow the call tree. You're gonna say, press 1 if you want to talk for your medical needs, press 2 if you want to talk to recovery coach. And that number is 24/7 number as well.
okay.
That doesn't mean that recovery coach will meet you on the street in the middle of the night, but they're going to tell you, hey, I'm going to meet you at 7 o'clock in front of the clinic tomorrow morning. I'm going to wait for you there.
Okay.
That's what that means, right? And then if they leave, they're going to follow up. If they don't show up, they're going to follow up on them why they didn't show up.
Population advocates like Ariana Ciancio, Jennifer Jones, and I know there's somebody in West Palm Beach as well. Do they all have access to that number, that 24/7 number?
That's the most advertised number we have. Again,
No, I know. I just want to make sure.
we are still best kept
everybody's
secret in the
talking to
town.
each other. Okay.
But we are still the best kept secret in the town. I'm just going to tell to this group, there is no reason that anybody in Palm Beach County for medical or mental health needs goes without the care. And if you have any issues with that, please give me a call directly, right? If you encounter issues. I'm not saying that you're not going to encounter issues. I'm just saying we build a system of care that outpatiently, we can cover all medical or substance use or mental health or psychiatric needs. We have enough capacity to do that. You just need to know how to, which door to knock, and occasionally lack of logistic support can fall through the crack, but I need to know about that.
Velma, can you put that phone number then in the chat? Because I have a lot of people that have been having trouble that I definitely need to get in that
Yes.
I'd be able to contact. Okay, thanks.
Awesome. We may put it on our state attorney website as well. I'll talk to Dave about that. Okay, great. Thanks. Thanks, Belma. Next up, any other questions? Okay, next up we have Nikki Soda. And NAATP recently, this year, did a workforce study, behavioral health workforce study. And I know that's one of the challenges that we have in Florida, especially like, for example, with peer specialists and residence administrators, certified recovery residence administrators. So go ahead, Nikki.
Okay, can you see my screen now?
Yep.
Perfect. All right, hi everybody. I'm Nikki Soda with NAATP, and we have done extensive research and have been collecting data on the workforce shortage issues. So everyone is aware of the challenges. So I'm going to kind of breeze through what the challenges are and talk a little bit more about what the solutions are that we are working towards. And as Al just mentioned, we created a workforce committee back in, it was the summer, and we have gathered a group of, there is 12 individuals, and they range from directors of HR, from large treatment centers to CEOs to some compliance and some compliance officers. So we really have a nice range of people. And part of what we have done is, as the addiction rates rose dramatically, as everybody knows, over the course of the pandemic, and more patients were arriving with greater acuity than previously before, treatment providers have been faced with exhausted and depleted workforce, creating greater staffing challenges in recruitment, hiring, and retention. And so one of the things that we really wanted to focus on was we needed to understand what the issues were. So we took a deep dive into that. And part of that too is being reinforced the underinvestment that we have in our insurance programs, and private and public. And what we found too is that in 2021, which I realize is 2 years ago, fewer than half of the people with a mental illness or substance use disorder were able to access timely care. And some of those groups are disproportionately impacted by those workforce shortages. So when I travel a lot, and I've been putting together different groups in all states. So Arizona Al was one that I went in Scottsdale. And what we find the number one issue right now is workforce shortages. Every single group that I have met with, and when we talk about what are your biggest needs, and these out of collecting all of the information from all the different states that we've been to, these are the top 5 issues that people are having: staff recruitment, staff retention and development, employee compassion, burnout, and how to deal with that appropriately, meeting evolving community needs. And that's an array of things that I have a full notebook full of what those are. And then DEIB, and ensuring that not only is there adequate staff, but is the staff diverse, and is the staff able to meet the community's needs? And so these are some of the other challenges that we have found in what we're specifically looking to help with solutions for. And so I would imagine most of the group has heard of the 5 R's, and those are retirement. We have seen a very, very large number of people take early retirement during the last 3 years. Relocation, because of COVID, there was a number of people who moved either to care for loved ones or to be able to live in a different area. Reconsideration, is this the field that I want to be in? Reshuffling, there was a number of different treatment centers that had to add a lot of different hats, and people were like, screw this, I'm out. And reluctance of being overworked and not being compensated because treatment centers weren't able to pay extra for the extra work that was being done. Growth of telehealth and telemedicine has been a huge impact. We have seen a very large number of clinicians that have left, that have not wanted to return because they've been able to create a private practice to employ themselves. Shifting expectations of employers. A very, very large amount of new demands was put on, not only during the pandemic, but expected to be kept up after the pandemic. And so these are some of the issues that we've taken a look at to try to see, okay, what specifically can we find some solutions for these? And I do want to say that one trend that our workforce group has noticed is that a large number of the therapists who, I shouldn't say a large number, excuse me, a small percentage of the therapists that have left to solely do telehealth, to go and work for themselves, are now coming back. And so what we have heard, what we've seen, is that the therapists are missing the environment that they were in within the treatment center or within a community. And so we are seeing a shift back from those that left to go work for themselves back to the treatment centers. These are just a couple of stats, and I'm just briefly going to go over this. They are included in the packet that Marianne sent today, but there is roughly 1.3 million providers that are offering behavioral health services. But what we're seeing is that 49% of the people that are in need of services are not able to get those right now. And a large part of that is because there is the shortage of providers, and the demand for services is increasing. So as I said, 49% of those are not able to get help, and 2/3 of the shortages fall in rural areas. And so one situation that I heard recently is there is a treatment center up in a rural part of the mountains of Colorado, and they have had to come up with some really creative ways to be able to recruit. And so what they've done is they've turned some of their residential cabins into employment housing to be able to get people to come and want to work for them. And what we're also hearing is that in this small town in Colorado, Amazon is paying significantly more than what the behavioral techs are making. And so it's making it very challenging for them to be able to compete because their budget has been slashed drastically due to COVID. So those a couple of the issues. So financial reasons with limited resources, reimbursement rates and student debt, education, lack of training to serve diverse populations and barriers to the workforce. And then, as I said, shortages in rural areas. And so, and those numbers, they came from the National Institute for Healthcare Management in DC. And so this is from the National Council. We work hand in hand with them, and they did a very vast workforce shortage study too. And so these numbers are included, and I'm going to skim over these to talk about our solutions. So what is the National Association doing? We put together, as I mentioned, a very active workforce group that's been going around. We've had a number of our advisory committee members that have gone and talked at some conferences, but for legislation, this is what we have done. We have learned that more than 4 in 5 behavioral healthcare workers believe that without public policy changes, provider organizations will be unable to meet the surging demand for mental health and substance use disorder treatment services. And so what we're doing is we're asking for increased funding and to expand the national loan repayment programs, and this would include the National Health Service Corps, the SUD Workforce Loan Repayment Program, and the SUD Treatment and Recovery, which is also known as the STAR Loan Repayment Program, as a means to increase access to tuition assistance for mental health and substance use treatment fields. So one of the things too that we have done is we're working with Hazelden Betty Ford, which is has several different master's programs for clinicians. They have slashed their rates for their online school, and they've also waived needing to have a bachelor's, which I'm not sure how they've done that, but they are doing that right now. And so that's Hazelden Betty Ford, their graduate school, and it is online right now. And so that's one of the things that we have worked to help elevate that and promote that program. We also support the implementation of the Mental Health Access Improvement Act. And so this in September was President Biden held a large press conference to talk about how they are doing some more enforcement of parity, which is, a step in the right direction. We still have a lot of work to go there, but this is going to help. This bill would allow marriage and family therapists to bill Medicaid and to provide support for the sector and really have enforcement on it. And so that's one of the things that we were there at that press conference and have put a lot of work behind that. And Jeff, I see your hand up. Is this about the public policy part?
Yes.
Yeah, go ahead.
Thank you for this, Nikki. Has the National Loan Repayment Program concept, has that been discussed to include physicians? Because, and I'll certainly leave this to Dr. Moran to chime in on, we collectively have been, I don't want to say pushing, but have acknowledged the lack of truly properly educated addiction psychiatrists in this field. And, we think it's hard enough for people to go to medical school. It's my understanding anecdotally that those who seek to be psychiatrists are looked at like second-class citizens in medical school. And I'm sure that those then that are inclined to go into addiction medicine are probably the ugly stepchild of the psychiatrist group, so to speak. So I'm certainly encouraged that we do some form of loan repayment program for people that would go into addiction medicine for a certain period of time, similar to what we do with underserved communities and certain populations. So I would hope that this increased funding would go beyond people that are clinicians and maybe also be discussed for the medical side, particularly as we as a state are pushing to have the Department of Health and AHCA, its Agency for Healthcare Administration, start to assume proper oversight of the space.
So Jeff, I can kind of put some light on that. This program already exists. Out of 15 of licensed social workers that we have in our general behavioral health and the substance use disorder program have loan repayment are part of this program. Many of our physicians are already part of this program. So this is not something that we don't utilize because this usually is offered for area of critical needs. Kind of, you have those kind of scores that if you practice medicine in certain facilities, you qualify for that. This is expansion of this program, but this exists in our community for a long time, and many of mental health providers already benefit from that. So I'm glad that we are expanding. If you go in those special fields, you qualify, but you might qualify by location where you practice already. There are many national programs that are already doing this. So she quoted here, like HRSA, like Health Service Resource Administration, we participate in that. We have the highest need scores. We have HIPSA scores of 24 for mental health. This is one among highest in the nation. What is calculated based on your landscape, right? Based on Medicaid provider you have in your community, density of your population, etc. But my organization heavily participate in that, and we have like probably 70 physicians that we hired. Probably 50% of them participate in this.
Yeah, thank you very much for that. And that's a very good point, that we are focusing on increasing expanding the funding and the outreach for it. And Jeff, also to follow up, so ASAM, which I'm sure you're familiar with, is very heavily in working on the physicians track. And so it's not that we are not. We work closely with ASAM. We're really looking at the other buckets that are there: the clinicians, the clinicians, the therapists, the nurses, the behavioral techs, and all the other workers that encompass the treatment center.
Thank you. I'll just wrap up. I think this is the single. I'm sorry, Nelson. I think this is the single most important issue facing our industry. That's like, Social Security and Medicare. The workforce is just not there, and everything Nikki said is true. I don't know what we can do, but Nikki, thank you for bringing this up. I think we need, as a task force, to focus on this more, particularly because of the positive economic impact that the treatment industry brings to Florida. So thank you, but I'm sorry, Neil, go ahead. I apologize.
No, I just wanted to jump in with some of the stuff that Nikki's been talking about, which is great. And thank you guys for the work that you guys are doing too. We've been also doing some stuff in the state. So I was going to ask if there's any certification groups involved with you too, because we have, because of the workforce shortage, adjusted, if you will, our requirements for certification in order to get individuals through the system a lot faster who can deliver services. One of the things we've done in West Palm Beach even was work with the school system. So there is a program right now where individuals who are in high school in the 10th grade, kind of a VOTEC type program, would become behavioral health techs, and they start working in the system. And then upon graduation, right before they sit for the test to be certified behavioral health technicians, I believe they graduated 47. It was their first year to do this program. And of the 47, I think only 20 plus took the exam, and of that, about 8 actually got certified. But not bad for the first opportunity, first bite at the apple. Currently, we're working with the Florida Behavioral Health Association, and we have working with Senator Gail Harrell on a bill that would allow individuals both certified at the bachelor's level with mental health and at the bachelor's level with substance abuse to be able to bill Medicaid as long as they're working at a community mental health center or a licensed substance abuse facility, and have a minimum of a bachelor's degree. Currently, if you're working at a community mental health center, you can already deliver the service. You just can't get paid by Medicaid for the service. So we're trying to expand that and working with right now DCF and ACA to push that through, but also to say if there's anything that we can offer, anything that we can do we've been more than happy to work with anybody, because as everybody has said on this call, this is a huge issue. And it's also at the lower level, not necessarily the psychologist, psychiatrist, but even the master's level folks, the folks who are spending most time, the behavioral health techs, the certified counselor, delivering a lot of the services and any support that we can get, we're pushing for these, so that to recruit more people to come back into the field, as Nikki said early on. But we're very hopeful. We've gotten a lot of positive feedback from the provider agencies, and hopefully Senator Harrell will push this. They're doing a very big workforce bill in the Florida legislature, not only just for behavioral health, nurses. It's going to be a very big package, and it's going to go through an entire workforce as an issue through multiple areas.
Neil,
Thank you so much for that. Sorry.
If I can, Neil, when that proposed legislation gets through staff and it actually exists, could you send me a copy so I can distribute it to everybody and we can discuss it at a future meeting?
Yeah, no, absolutely. And I have a meeting with Gail, Senator Harrell on Monday to follow up. We've given them some language and how we can move forward. But I would say anyone who has the opportunity to work with Senator Harrell, please also inform. It's one thing to hear from the certification board who's going to certify folks. It's also to hear from people within the community, because her district comes down into West Palm now.
Right. Excellent.
Hey, Al, can I
ahead.
just jump in, and then I do have to jump, but this very important discussion. I think part of it, Al, I'd like to go a level above, because I think we're trying to solve workforce issues with old payment models, and if we don't address payment models, we're likely not to solve this workforce model. So workforce issue. So, what I'd encourage us to do, and I'd love to have us all drive this conversation at least, here in Florida, there's a body of work out of the Alliance for Addiction Payment Reform. They have a recovery home medical payment model. There's also work out of O'Neill Institute at Georgetown University. Al, I will gladly send you both of those reports, and would love to have the task force consider those bodies of work at a future meeting.
Great. Thanks, John. Appreciate
Can I
it.
ask a quick question, Al?
Oh, is that Rachel?
Yeah, so Nikki, and obviously I support part of this for the reasons that you're doing it. Does anyone else fear that this is going to be taken advantage of and we're going to have lower level, people doing jobs that already they're already some of what they're doing and they shouldn't be doing, such as groups and supposed therapy. And I guess that's just what comes up with me, is that we know that people are taking advantage. They do everything they can to save a buck in the field. And I get it. I'm a business person, but this scares me, gonna be honest.
Well,
Al, may I, since my hand hasn't been, my hand is the wrong color.
I was just gonna, you can't see it at all, or I would have
You
called
can't see my,
Right.
Nikki, I think it's great. I'm talking now. I want to share Rachel's concern. I really appreciate what Nikki is doing here, but back to what Neil's talking about, and this connects to Rachel's concern. My concern, if I put not my FAR hat on, but my plaintiff's lawyer's hat, is that what I see firsthand, record to record, client to client, is that the people who are rendering the actual services are not at all certified, qualified, trained, or anything. So I can give you many case examples. So I'm very much in favor of all people who have access to patients or clients in this way having a basic certification level, right? It's not going to teach them. They should not be supplemented as a therapist, counselors, and the rest. They should be doing what they're designated to do, but they need to be certified, because I can reiterate a number of tales where it's just they did stupid things because they didn't know any better, and people were hurt and died, and I recovered money. So let me just put it that way. So I'm very much in favor of the certifications and the training, because that's what we need to have. And that will also enable them to be doing stuff and maybe move ahead in their careers and get other degrees or not, whatever. But, and I understand what Rachel's point is, that the reason we even have BHTs is a cost it's because it costs less to hire them than it would to hire actual registered nurses, right? Or people who are really trained and certified in this. So that is the truth. And that's why I think we need to go under the Agency of Healthcare. I could speak all day on the subject, but I'm really in favor of as much training as possible.
I was trying to figure out how to make lemonade out of the lemon of only 8 people taking and passing the exam of the 47 that went through
Right.
the program. But I think that's the guardrail that we're talking about here.
Yes.
So, you know, we're getting ahead of ourselves. I share the concerns, because there always are concerns that people and in this case, providers will take advantage and put people in jobs that they're not qualified for, but we have that anyway. So it's only a plus to have more programs to get people more knowledge and have to go through and pass exams to be able to practice on the, you know, on the level that they're designated to practice. So we're going to have to move on unless somebody has a pressing question or need, because we've got to get to the legislation. And Nikki, I don't want to cut you short. So what else do you have for us on? You just ended your PowerPoint.
I did, because I think you made it sound like it was wrapping up, but just to address Rachel and Susan's point, believe me, if there is anyone who is big on regulations and ensuring that the appropriate people are providing care, it is me and it is the association. And so these are tools that we are trying to use to provide to get some more qualified people in. So as far as the certification, that's kind of over. Not over, that's kind of moved over there. What we were talking about right now is the loan repayment to encourage people to go to school, to help support them to then pay for school, but encourage them to get into school and to get into those certifications. And Neil, we are working very closely with NADAC, because they are doing the reciprocity for now there is, I think it's up to 15 states that now are allowing you to be able to practice intrastate instead of having just one state that you're licensed in. And so that's a big benefit too, to be able to work across state lines. We talked about this very briefly at our last meeting, but NAATP has produced a salary survey. Al, I'm making a huge note. I will not get off this call without sending it to you. This salary survey has gone through and is a helpful tool to HR departments to know what other treatment centers are paying behavioral techs, chefs, janitors, everything across CEOs to marketing and outreach individuals. And so this has been a big study that we produce every 2 years. Because of COVID, we did it last year and this year. And so we're working to make that more robust, to be really a helpful tool for the industry. So more than happy to answer any other questions. And
Nikki, were there some other slides that you wanted to present? Because I wasn't trying to cut you off. So if you want to go back, if there's a couple of ones that you think are beneficial that you want to go to, feel free.
Yeah, that's okay. Just please know that on our website, we have a litany of workforce resources specific to substance use disorder treatment providers and mental health providers.
Okay. Any other questions before we move on to the legislation? Okay.
Sorry, I have a question. Sorry,
Sure.
Al, I had to unmute myself. I'm interested about Scottsdale, Arizona. How you say that? Scottsdale, Arizona.
Scottsdale.
They have a very robust mental health system there. They have a central scene facility that is kind of state of the art and model for national kind of crisis now models. Is that the reason that you choose that location? Because they're utilized a lot of local resources, or it was just not connected to their mental health ecosystem?
it was not connected to that for the reason that it was there. But we talked about that a lot, and I was able to see it. So, but that was not the reason. Sorry.
Thank you.
Okay,
Al,
Yes.
Al, Jeff, I just want to just correct something that was said and then move on, because I put it in the chat. Just something that Neil said that he's right, which is good, is that at least I know in Palm Beach County, the public schools, they have these academies, and there's a medical academy where my wife's a teacher at West Boca High. She used to be the head of the academy at Lake Worth, and it was introduced, and she helped write the curriculum with my help and others in school on the ability for these kids to learn everything about behavioral health, including behavioral health tech. And just Neil's point was, these kids at the end of their senior year are eligible to sit for the BHT certification. Neil's point wasn't that only if you passed, it's very few take it because it costs money to take it. And they asked, the school says, look, well, school will pay for it, but let us know if you're taking it or not. In the first year, few did, and of those who took it, not many passed. And it's not so hard, it's a newer program, but we're just talking about workforce. And so I want to encourage the fact that if there are high school graduates that are passing the BHT certification exam, being a BHT is a glorified babysitter. That's all, let's be honest. So if we have high school kids that are graduating and passing the certification exam, I don't want to say, oh, those people need to have a bachelor degree to be a BHT, because that undermines the entirety of what we're trying to talk about, which is filling the necessary workforce. At the top, we've already passed a law and rules that only certain people are allowed to give therapy and do certain things. We amended 397. So I don't want to get into a conversation of, oh, we need to pass a law for that. We already did. So what Susan's talking about, I don't know if those are older or not, but the law today that we passed is that, to the point of whether there's going to be abuse that Rachel was talking about, we fix that. So if there's still abuse, we need to talk about that, but we passed a law to fix that.
all right, Neil?
Yeah, and just to reiterate, I mean, the reality of the situation is that we have a huge workforce shortage. Individuals who are certified at a bachelor's level are working in a community mental health center, or they're working in a licensed substance abuse facility. They're never working independently. Every certification that we provides for that type of environment. We never provide certification for somebody who's going into independent practice. It's already there. It's called an LCSW, an LMFT. That's what you do if you want to practice independently. But in order to get a stopgap of individuals currently even delivering those services legally in every substance abuse and community mental health center in the state of Florida, but they can't get paid by Medicaid. And to be clear, the peers that are also providing, they don't have their own Medicaid code. They have what's called a downward departure code that you get paid for, but it's not. And this package is also about increasing how individuals feel about getting into this as a job, as a career. Because when I got into this field in the late 80s, early 90s, there was a career path. You could go down to, someone had mentioned University of Miami. University of Miami had a big addiction training center. West Palm had a huge addiction training center. Those have gone away. They're not around anymore. What we've done is we've taken every individual who had a connection to substance abuse and mental health, and we've wrung out their empathy as hard as we could to get them to work into this field, whether it's guilt, whether it's whatever. We've taken full advantage of that. When we pay peers $4.80 per quarter hour for Medicaid reimbursement. Now we can pay higher if you go to the managing entity, and they can pay a higher rate. But what we need to do is there needs to be a full career ladder of where prior to this, where we are now, there was a rung on the ladder for everybody to see themselves and where they wanted to go and move up that ladder and decide, okay, I've got a bachelor's degree in certification. I want a master's degree and a license now. That's my next step. That's where I'm going. That doesn't happen anymore. So if we're building, and going to pay for reimbursement of education, we have to create a space where people can become familiar with the industry and decide that this is the career I want, because that's gone. It's not there anymore.
All right, thanks, Neil. Tori Perfetti, you have the last word.
Thank you. And I just wanted to chime in too. I realize that we're all moving forward and there's a lot of moving pieces. A lot of people brought a lot of things up and things are getting a lot better. One of the reasons why BHPs, and to Neil's point with, the empathy side and who wants to work in this industry, real actual treatment isn't simply stabilizing. It's long-term outpatient care, which dovetail into building a actual treatment plan, but then building a sponsorship family and a program, right? The AA and NA side of this is part of actual treatment as you run yourself from if you had to go to the ER, then you go to your detox, then you go to your PHP, IOP, OP, you're building within your sponsorship community and your family, the big book, the 12 steps, the so forth and so on that go with treatment. And I usually don't hear a lot of that when it comes into this. And a lot of BHDs, they're lifers, right? And they need a career path and they want a career path. These are people who started in addiction, went into active recovery and lead a path of recovery, some of them 30 years. Right. And they want to work in this industry because that's part of their life. So I agree with that. And I'm appreciative of trying to help move that forward legislatively as well. But a lot of the people who want to work in this industry, they could not wake up in the morning to do anything else. And I know that we don't hear a lot of the, for-profit side of the industry, but the people that we hire, a ton of them, they are lifers. So I just wanted to include that the BHD is an essential aspect of treatment because a lot of them have gone through it. And when you're an addict, a nurse or a doctor or what have you, when you're trying to self-associate and say, hey, I'm in the first week of my treatment, who can I see has done this? A lot of times they'll look up to your peer-to-peer support. They'll look up to your BHTs. They'll look to those people who were there where they were 5 years ago. So just as a comment.
Thanks. Okay, let's move on and put the legislative package up there. We're going to go down through this. Most of these we've discussed. They're non-controversial. They're tweaks, if you will. I was very pleased yesterday at the legislative delegation behind Mounts in West Palm, where the county commission was there, as well as most of the local legislators in Palm Beach County, that they didn't have any questions on this first provision. The key here is we're not talking about your ordinary and normal sales tax if you're a business, but the taxes that have to do with the discretionary sales taxes that have to do with tourist development, tourist impacts, transient taxes, accommodations, etc. That recovery residences are exempt from those. And I didn't get any pushback, which is good. So unless anybody has any comments for this section, I think we're doing pretty well on that. We may get a local rule usurpation argument later on, but I think Terrell and you, I don't know what you've been hearing, if anything, but and you too, Tom. But I think that everybody realizes that this is not a tourism industry, and everybody seems to be pretty okay with this. All right, seeing no hands, let's move. Let me go ahead and move myself here to. Okay, this is a big deal on 397.311. We have never defined levels of care within certified recovery residences, with the NAR standards and the FAR standards, which are not in lockstep when it comes to level 4. But here we've basically taken the playbook of FAR with regard to their definition of the 4 levels of housing. I'm sure you all have had a chance to look through this. But I think it's really important, since we're starting to deal with specific issues that may deal with the level of a house. In other words, the ancillary the ancillary issues in the house, the ancillary care, as well as the connection to a recovery treatment provider, a service provider, such as level 4 and level 3. So any issues with that? Okay, seeing no hands. The definition of community housing is also another cog in the wheel here of being able to discern the difference between an Oxford house and a house that is part of a day or night with housing component license. So we're looking at this as a community housing definition as dealing not primarily, but solely with level 4 level of support, as defined now in the previous statute that we discussed. So community housing is a certified residence. This is all to do with certified residences, not a sober home that's unaffiliated. And it doesn't have to do with Oxford House either, because Oxford House will never be a level 4 residence. So anyway, community housing is a certified recovery residence offered or provided by a licensed service provider. So there's direct connection to the highest level of care that provides housing to its patients who are required to reside at the residence. Again, required to reside at the residence while receiving intensive outpatient and high levels of outpatient care. I don't know if anybody's going to have an issue with the intensive outpatient or not. I've heard none so far. Normally, when we look at the level 4s, they are day or night. So they're 30-hour, 25, 30-hour of treatment programs, as opposed to intensive outpatients, which is 9. But anyway, we've got that in there. See what flies. That are operated by the same licensed service provider. In other words, it is a house that is attached to the actual service provider. A recovery residence used by a licensed service provider that meets the definition of community housing shall be classified as a level 4. So this would mean that certain intensive outpatient programs would now fall under level 4, whereas it's, to my understanding, it has not up to this time. So think about that as we go forward. If anybody can see where that might be a problem, I haven't heard any yet. So with that, unless there's a raised hand, this, by the way, this legislation, as we're going over it, the draft, has been submitted to staff in both the House through Representative Caruso and the Senate through Senator Gale Harrell. And that doesn't mean that the staff is going to call me up and look at me like I'm made of green cheese and say, what the heck do you mean by this? Which we'll have to discuss with staff. But this is not in stone. None of this is in stone, as you'll see when we get to the MAT section. All right, now let's go on to line 84. We have a couple of sections, and Neil, if you have any problem with these, please chime in, because you weren't at the last meeting. And we did discuss this. I don't think these, I think this is good. But one of the problems that we've had with recovery residences is, and recovery residence administrators, is when we have a hard and fast deadline of 30 days, for example, there's an issue with, hey, you got a good provider, you've got a good house, they're doing everything right, but they can't find a certified recovery residence administrator because there aren't any. But they're chugging along, they're doing everything right. We're looking at 90 days instead of 30 in order to retain another recovery residence administrator, and giving some flexibility to FAR that the credentialing entity may revoke, not shall revoke, so that all things considered, if they're just dogging it, you know, you do have the discretion, FAR, to go ahead and revoke, but then you got to, where are the people going to go that are living in the house? So we don't want to take that lightly if it's a good program operating well under the FAR system. Now let's look to lines 84. If a recovery residence is certified CRRA has been removed again due to termination, resignation, or any other reason, and has been approved to actively manage more than 50 residents pursuant to 4871, the recovery residence shall have 90 days to retain another certified recovery residence administrator, again, pursuant to the section. So even in the larger programs, the level 4s, we're still, if it's a good program, giving FAR the discretion to not whack the license immediately based on statutory requirement. This is just cleaning up, starting with 92, line 92. It's just cleaning up the language to mirror the language that applies to providers. So making the certified recovery residence language the same. So for the providers, if someone is arrested and awaiting final disposition of, okay. And we didn't have that, we're just cleaning it up. It's really just a housekeeping, because, you know, if they're awaiting final disposition, okay, they have to be removed. Okay, so anyway, if there's no questions on that, let's move down to line 112. Okay, this is one where we need to have a discussion. The way we originally had the draft written, recovery residences may not deny an individual access to housing who has been prescribed federally approved medications that assist with treatment for substance use disorders by a licensed physician or an advanced practice registered nurse registered under appropriate section 4 of chapter 464 solely on that basis. Okay. This was recommended by FAR. I don't think, although the language does give some flexibility to the home to reject somebody on another basis rather than just the MAT. And this is all MAT. This is buprenorphine. This is methadone. This is any prescribed, FDA approved medication that's delivered by a physician or, again, appropriate advanced practice registered nurse. My problem with this is think about people who go through the addiction stabilization unit and they are immediately go to JFK on an overdose, even better, because they're an active user at that point. They are not in recovery. They are not in treatment. One could argue that issuing a prescription for buprenorphine means that you now are in treatment. You're in treatment, and therefore you are covered by the FDA and the ADA. Another argument could be made that being that close to using, you're really still a user. The pushback that I have gotten from people, not only in this meeting, but also I've called a number of people on the outside, is that we, in a level 1 and 2 house, go ahead and put the other draft on there. At a level 1 or 2 house, you may be polluting the house. You may be causing a trigger for the others who are in sobriety by introducing someone into the house that is that close to the addiction and is actually on a MAT to address the cravings of addiction, that close to the active addiction. Not so levels 3 and 4, in my opinion, and I want to hear from you. Not so in the level 3 and 4. So here's how this is inartful. This will never be the ultimate language, but this is where I'm going with this, and let's talk about it. So we have 13, and we split it up into 3 sections. First of all, recovery residents, including levels, all recovery residents, because if you're not certified, okay, We may want to exclude, Oxford House because they're a level 1. I didn't put it in here, but this is the concept. If you're in a level 3 or a level 4, you're actually in a program. You're not in harm reduction. You're not dealing with a peer who's trying to bring you into a program. I'll call on people once I finish introducing this, Dr. Moran. Okay. Level 3s and 4s, you know, especially level 4, but I'm thinking level 3 as well. Correct me if I'm wrong, because both of those are attached to treatment. So you're living in that house, you're in treatment. Okay. Much more likely that the people in the house are in the same position that you are in. They're not 9 months or 12 months into their recovery. They're also in active treatment, especially in level 4, they are by definition. Okay, so recovery residences, including level 3 and 4 programs, may not deny, again, individual access to housing, et cetera, if it's FDA approved, a prescription by the appropriate person, medical person, solely on that basis. Okay, all right. Now that's all recovery residences that are not certified. We'll figure out how to exclude Oxford House as well, including level 3 and 4. Then we have B. Notwithstanding subsection A, this section only applies to level 1 and 2 programs. We could add there and Oxford House. Well, the level 1 and 2 programs are defined in 397-511-5, where the individual seeking access to housing has been in treatment with a licensed service provider for a minimum of 30 days. Spitball. Okay, what bothers me or troubles me, what could possibly go wrong, is somebody goes to an advocate, and the advocate, and they've just gotten their first buprenorphine prescription. They're a click away from having overdosed or using, and that advocate goes and browbeats a level 1 or a level 2 house. You got to take them. And arguably by the statute, they do, as it's written originally. So that's why I kind of divided it up. I don't know if this is going to fly legislatively. Dr. Moran, I'll start with you. You have your the first hand up, but I do want to hear from a number of you.
Thanks, Al. First of all, I have 2 things. One is, may we add physician assistant to the providers?
Wait, say that again. Add what?
Physician assistant.
Is a physician assistant FDA in the FDA loop for that?
Yes.
Okay, sure.
The second.
If that's SAMHSA, yes.
Yeah.
Okay.
The second point is that there are many outpatients who present with a mild opioid use disorder who may begin buprenorphine and really have an effect that's relatively quick. And so I'm afraid they would be denied this housing simply because they're newly in treatment.
That's a good point. Now, keep in mind that this statute does not forbid a person from going and applying for housing. Okay, saying you know, for example, your intervention to a house that accepts MAT, and this is part. If you notice, the effective date is January 1st of 2025 to give FAR more of an opportunity, and we may even push it to July of 25 to give FAR an opportunity to educate the houses, the most of the houses throughout the state that are biased right now. A lot of houses say they take MAT, but all they take is Vivitrol, okay, because it's non-opioid. But again, this doesn't prevent you from intervening, calling up and finding a FAR residence, 1 or 2. You know, they could go into a level 3 that's not affiliated, but I think most level 3s are with a particular program. But again, the problem is, where do you draw the line? How do you legislate well, if the doctor says he's all right, you know, you're kind of putting yourself in jeopardy too, because if that person pollutes the house, I'm not worried about, you know, somebody taking the buprenorphine and selling it to other people in the house. I think that's overplayed. You know, people who have a buprenorphine prescription are using it so they're not using. And however, you know, diversion. However, I am worried about level 2 houses becoming a person in this position becoming a trigger for others. Anyway, your 2 points are duly noted. The second one, again, you're not prohibited from trying to find a house, and the more educated that the houses can become and understanding, you know, if they're under your care for 30 days, they're in treatment for 30 days. Okay. So yeah, after 30 days, they would be part of this again. And these houses can reject for other reasons. And I don't think anybody's going to have a lawsuit over it. But again, we're trying to do this. Tori, you're next. You got your hand up. And then Susan, you're next after that.
Yeah. So, and I think part of this is an educational situation as well, because we're looking at a couple different issues. On the one hand, let's say they do go to a stabilization unit, right? A hospital stabilization unit and or a clinic that a doctor, a psychiatrist says, hey, this is what you're going to be prescribed. And then the individual goes to try to get placed into a level 2 home. One of the things is, and you just pointed it out, the intent of this law was to create an environment where you can't say no just on the basis of Suboxone. But you could say no, as far as I am aware, based on what this would do for criteria, right? As a level 4, if you're having somebody stay with you and they're going through what you were describing as post-acute withdrawals, right? Where you're getting triggered to use and you're that close to where you were just using. So on the medical side, you're being prescribed medications to stabilize you and detox your system or what have you. And then you're going into recovery residence at a level 4, which is really your more outpatient, specific outpatient center. So PHP, IOP, and then OP. The issue I think that FAR was having is that if you're a level 2 and someone calls you up, what ethical decision are you making here, right? If the individual has no insurance or is underinsured or has no means whatsoever, and they're coming from a hospital and they have nowhere else but the street, does the level 2 say no because they are having post-acute withdrawals and they don't meet criteria to be in a house that should be with people who were already graduating through most of their levels of care? And, you know, the term treat them and street them, right, from a stabilization unit. So I think there was a concern ethically, do you accept that? The other side is ethically, can you accept that? And I don't think that this part of the bill was meant to get that far into the weeds with does a level 2 have the appropriate level of care? Because the honest answer is they don't, right? A level 2 home is not appropriate for someone who might have just gone to a stabilization unit on fentanyl and was released 24 hours later with a script for Suboxone and then gets put into a level 2. That the honest answer is that's not a suitable situation. What this bill was meant to do was to stop people from saying, if you got through detox, you got, or we'll even start at the ER. You went to the ER, you went to detox, you maybe did some residential, and then you go to PHP, IOP, let's say you're graduating all those levels, and now you are going to your final transition to a level 2. That's what this was meant to do, is say you can't just deny somebody because of. So I think we have some issues of appropriateness for the client they're taking in. And this is where, you know, your phrase comes up, will somebody drive a dump truck through it? And I don't think that was the intention of this. And I think if a level 2 place is taking someone right away that's inappropriate, they might not be appropriate to being an owner of that type of program. And so I'm fine taking a look at this and seeing if there's guardrails to put on it. But I think FAR's position, and I know Susan's going to speak and Josh and Heidi and others, but I think the position was you shouldn't be denying people who are on subs. And I think what you're bringing up is I don't know if a stabilization unit should be calling a level 2 up to try to place somebody out of their care, right? Or a hospital in general. And I think that might be the difference in communication. I don't think it's appropriate to have that phone call. They should be calling level 4s and seeing if there's an ability there. And this really needs to talk to the Palm Beach County and the state. If these are underinsured people, there might need to be something grant wise where we're trying to help some of these people get into a level 4 that needs help, or to CARP in that type of way, right? So that's what I think this is to a degree.
And that's actually trying to do what you just talked about, which is to discriminate between, well, discriminate's a bad word to use, but to delineate where it's appropriate to go. I'm not worried about somebody from the addiction stabilization unit clinic calling up a recovery residence. I'm more thinking about citizen advocates or people who are working in that capacity, and somebody needs the house. Go ahead, Susan, you're next up.
So one thing that has been clarified today is the addiction stabilization unit is actually an outpatient program, right? So the patients are not lost in, I mean, hopefully they stay connected. But the issue that Tori raised is what we've been talking about, is the ability for a house to say this is an appropriate fit may be completely appropriate, right? So maybe this is a person who's got multiple diagnoses in addition to, being diagnosed with substance use disorder. They're delusional, they're schizophrenic, they're things like that. They're not appropriate for a level 2 house necessarily. It doesn't have anything to do with what medications they're prescribed. It has to do with their presenting problem. That wouldn't be a good fit for a level 1 or a level 2, because these are more the model of the social model as opposed to the medical model. Having said that, it is very clear to me that the recovery residence operators should not be practicing medicine. And I think this bill addresses that specifically, right? Is they don't get to decide. So that's why this is good. I'm okay with the, clarifying it between the levels. I mean, and then the reality is, and I love every advocate in the world, there is money, there is some county money, there's grant money to subsidize housing for somebody who's on MAD, right? That's what Rebel Recovery has. So that's important to help get the other end to take these people. Now, they may say, you don't have enough money. Our rent is $300 a week. If you can't make it, they have a right to turn them down because they can't pay. So, I mean, there are other ways to deal with. I think for the task force and this board to take the position, because this is already a FAR policy, right? I mean, if you are not taking MAD or rejecting MAD, you're going to have trouble with your certification. Okay, that's eventually going to happen. This is just codifies it and makes it clear, but it still allows the individual owners discretion as to the appropriateness of their placement, and they should be doing that.
Okay, before I go to Neil, Susan, can I take from what you just said that you would be in favor, and I think Tori, I'm also hearing that from you, that you'd be in favor of the earlier version, which says solely on that basis.
Yes.
When you do say solely on that basis, I believe as in terms of statutory construction, if they come up with another reason, such as the ones we're talking about, which are valid reasons, not to take somebody in a level 1 or 2, then we really are achieving what we're looking for. We're just eliminating the knee-jerk, the knee-jerk discrimination that's going on in some of the houses. Neil, you're next up.
I agree, Val.
Okay. Neil?
Thanks, Al. One of the things I was thinking about was, could this be something that could be addressed in the FAR standards for the level 2 homes, so that you make it, if they do bring in the schizophrenic, if they do violate that level, those level 2 standards, then their entire certification for that level 2 home is in jeopardy, or is available for sanctioning, rather than dealing with it in statute. But
Okay, a good point. I'm a little, I know how thin that FAR is stretched right now, with what they're doing. Having this in codified in statute would probably help them.
Yeah.
But anyway, Josh, I'll let you discuss that, or you had your hand up, so go ahead.
Yeah, thanks, Al. So just to pair it, Tori and Susan. So it's really when an individual's in a level 4 receiving treatment, they're on a MAT protocol. When they get ready to discharge, part of the discharge plan that the case managers may be doing with them is to get them into a FAR certified residence or a safe placement elsewhere. And we've had cases where these individuals don't have any place to go because level 2s are saying, you know what, I don't believe in this Suboxone, so I'm not taking it.
Right.
So that's what we wanted to fix. And in regards to your specific concern and what Neil just brought up too, all of our certified providers have a screening policy that we require. And in that screening policy, it's going to state your minimum criteria for acceptance, which is 18 years old, willingness to engage in a program of recovery, the ability to pay your program fees, and a minimum of 30 days sober, for instance. And then exclusionary criteria would be also inability to perform ADLs, any kind of psychiatric manifestations that would prohibit you from engaging in a program, in our programming, and maybe some legal offenses like sex offender status is generally, registered sex offender would prohibit you from being accepted into the program. So all that could be in a screening policy. So when you have an individual that's an advocate that's saying, hey, no, you got to take them because you can't deny based solely on this MAT medication. It's like, well, I'm not denying based on that. I'm denying based on they don't have the minimum 30 days sobriety that we require here.
So do you have does FAR have like in the policy manual that each recovery residence will develop their minimum standards for? So you already have that akin to the, say, the DCF rules when they interpret a statute or have something to at least give people a
Yes, we do.
all right.
Yes.
Right. That's great. Thank you. I'm now back to the original. And I'm actually going to put the original one back on the screen, the original in the omnibus legislation. And while we do that, I'm very uninclined to call on somebody whose name is iPhone 6.
It's Doctor.
Who is
It's
it?
me.
Yes.
I'm sorry.
That is the Simeonidis.
Oh, okay, John, go ahead.
I'm sorry, I
didn't
have
know
to fix that. I
You
don't know
normally
why.
have your name on there. Okay. All right, go ahead. What do you?
Okay, it's great. Of course, it's great conversation, and I'm glad to see that there's certain standards. But really, who's making the decision about what level of home level is the appropriate one for that person at that specific time? I mean, because things keep evolving. I mean, and maybe someone is more unstable in the beginning or less stable later on or stable from the beginning. Who and how is that decision being made?
Well, when you look at the 4 levels, which is one of the reasons why these are the accepted levels by SAMHSA as well as NAR and FAR. The only difference with FAR and NAR is level 4, there's no on-site treatment in Florida in a level 4, whereas with NAR standards, there is on-site treatment, meaning group sessions, etc.
But is it the
those
home
levels
making that
really
decision,
dictate
or who? I mean, who? Or is it the provider? Is it the physician making the decision? Who is saying this person should go to level 2 or level 3 or 1?
Okay. Somebody who is in a program like a PHP, and now we're kind of expanding it to potentially an IOP, where they're in intensive forms of treatment and the provider owns the house. They have to live in that house in order to, they have to live in the house in order to go through the program. And in most cases, it's part of the component license. That defines level 4. and in some cases, level 3. Level 3, there's a connection to treatment. Level 2 is a step down, where level 2 now is somebody who's post-treatment or in a less aggressive form of treatment. And level 1 is basically a democratically run Oxford House. So we already have the appropriateness of the various levels accepted by SAMHSA as best practice. So people fit into those levels to where they are in their recovery. So somebody who is in intensive forms of outpatient treatment would be going to the level 3s and 4s. And then somebody who's transitioned to a lower level that may have a house manager, but they really come and go as they please. They can be in treatment or not in treatment, but they're post-intensive treatment. So it's generalized somewhat, but that's the way the 4 levels work. Level 1 is a long-term. We're going to talk about transient use and short-term stays at recovery residence later in the next section or the next several sections. But does that answer your question somewhat? I mean, there is a standard and there is a system. And let's see.
Al,
Tori,
it's Jeff. I didn't raise
Jeff,
my hand.
I don't see your hand up there, Jeff.
I know. I gotta find it.
Okay, while you find
I'll
it, I'm
find
going to
it.
go to Teresa Verdol. You have a comment to make?
Hi, good afternoon. Can you hear me? Okay.
Yes. Yes.
Hi, I'm
please.
Teresa Riddle. I'm with the Office of Substance Abuse and Mental Health, Department of Children and Families in Tallahassee.
Oh, good. You're here for instead of Lee today. Okay.
Yeah, I didn't know she was going to. I just have a couple comments. One, I'm not really understanding why this is being proposed, except for I understand that there are concerns that individuals are being denied access to housing. However, these individuals, from the way that I'm reading it, already are covered under the ADA. And I know you mentioned it, but I just feel like I need to reiterate that this is already a federal protected class.
Yeah,
so I'm not sure if it needs to be statutory.
That's a great point. The problem is this gives FAR the ability to patrol. The ADA and the FHA, arguably, one could argue, especially people who are just starting treatment, are they active users? If they're active users, considered active users at this point, they're not covered by the ADA, FHA. And the other thing is, we've been telling providers that they're violating the ADA and the FHA. And correct me if I'm wrong, Josh, but I believe they've been told that this does violate the ADA and the FHA. We've never had the DOJ take a case like they do with providers on a housing situation. But that's a very, very good point. Do we actually need this? And let me hear from from the rest of you. Tori, you've got your hand up as well, and I see Neil.
I just wanted to add
Okay.
one thing, if I may.
Please.
I'm not sure what would preclude FAR from already including this. You say it gives them more teeth or ability to regulate this, I assume is what you meant. But is there something in here that doesn't allow them to already look for this and require it as part of certification? That could be a policy decision versus a statutory requirement.
Well, it's kind of like the department where you have a statute and then you create the rules around it. What I think that FAR may have been thinking of, and maybe Jeff Lynn or Susan, you can chime in. There's a due process issue with FAR. So if they get into an argument with a level 2, say, program, and that level 2, and the only thing that FAR has is to suspend or revoke a license. That's the only power that they have. Okay. And so what I want to avoid, and I think we're trying to avoid with this, is to have guidance in statute so that they can do their job without the worry that they're going to be there's going to be a hearing, a 20 hearing or something like that.
Understood. There is just a large, well, there's a housing crisis, a housing affordability crisis. So the concern is that this may add to that issue for individuals who, as many mentioned, may not have housing or are unstably housed.
So
by requiring this.
what do you mean? What do you mean by that, Teresa? Do you mean that some of the FAR programs may close and the houses won't be available, or how
All of the
does it
above.
affect the
It
housing?
could, the fact that a provider or a recovery residence may not even open because of these restrictions, or providers may close because they can't receive or accept certain individuals because of the statutory requirement. That's why I think it would be more appropriate to have a policy on this. I understand the concerns that you mentioned, but it could be also encouraged by the statute versus making it a mandate. Also, the managing entities could make that a requirement for funding or supports, things of that nature. Just
Okay.
other options might be more.
That's a good point. When SAMHSA recently, in the last month or two, came out with their best practice, which included MAT, by the way, all forms of MAT, as the best practice in recovery housing, there's a little more, I think, wind under the sails of this particular.
Agreed, but if you'll notice, they didn't require it either.
What's that?
Agreed, but they didn't require it either. They still don't require
No, they
it.
can't.
They
SAMHSA can't require.
consider it a best practice.
Yeah, but the upshot is, again, if there's another reason other than what we've just discussed, which would be an ADA FHA violation, if there's another reason, they don't have to accept the person. And again, if the person is inappropriate for the house because they're just been given a buprenorphine prescription, they're not going to go into a level 2 house because that's a reason, that's an articulable reason other than the fact that they're just on MAT, is that they're not in treatment and they're too close to the actual use. But I want to hear comments on those. Are good points. Thank you. And Corey, you're next up. Then we'll keep going. Go ahead.
Al, can you hear me? Okay.
Oh, Jeff. Oh, you okay? Jeff.
Yeah. No. I think for Teresa, I don't know where she went. I'm squirming here. And I'm glad the question was asked. I just feel that each time we have these meetings, we have to revalidate and substantiate why these were proposed. And so at the beginning of the session, I put together not only the proposed text, but the entire justification why. And then rather than pulling the justification back up, I feel like we're going, hey, yeah, why are we doing that? And it frustrates those who are so personally involved with these things and give a lot of free time and effort. They feel like we have to defend these things. So I'm just going to say, and nothing for Teresa, thank you. Those are great questions. Just the general questions should be like, here's the answer. And the clear answer is under section 397.501. It's entitled Rights of Individuals. Okay, individuals receiving substance abuse services, need to change that, from any service provider are guaranteed protection of the rights specified in this section. Okay, part 1, right to individual dignity. Part 2, word for word, right to non-discriminatory services. Let me read it, please. Or you pull it up. Service providers may not deny an individual access to substance abuse services solely on the basis of race, gender, ethnicity, age, sexual preference, immunodeficiency virus status, prior service departures against medical advice, disability, or number of relapse episodes. Service providers may not deny an individual who takes medication prescribed by a physician or an advanced practice registered nurse registered under, Chapter 464, access to substance abuse services solely on that basis. Okay,
So
then the service providers who receive. Okay, so
let me just I apologize, but I want to get this rolling. Everything you said is absolutely true, but a recovery residence is not a provider unless they're part of the one license that includes recovery residences day or night.
Right, which is why we are proposing the statute,
Yeah.
because there are a vast majority of people in this
Okay.
state that are in level 3, level 4 treatment programs, and they shouldn't lose that right that, Teresa rightfully pointed out, it's an ADA right. It is an ADA right. So all we're saying is, look, housing providers, you can't say, oh, I don't accept MAT, when the service provider that is referring to you is required to not discriminate. And we're trying to start to trickle that into level 2, because the level 2 providers, unless Dr. Siamides or Dr. Andrick or any other doctor here can tell us why someone in a level 2, which is a non-treatment level house, needs to be on MAT, we're trying to just fulfill the mandate of DCF that requires that treatment providers not discriminate on the basis of someone's MAT status.
Okay, all right, Tori, you're next.
Yeah, Al, to your, I think about 10 minutes ago, when you said that you would bring up the original solely on the basis, I
Yeah,
think
it's up there now.
Yeah, I'm fine with it too. I know that Schlossman and Cabot and others might chime in, but I don't see a problem with that, because that was the intent of this, is to not solely deny. And look, as far as criteria and who's choosing, especially because the majority of this is within an insurance-oriented participation, right? Whether through the insurance exchange or through out-of-network, which is much, much less now utilized. The insurance exchange and in-network is where everybody has maneuvered. The criteria also dovetails with ASAM 2.1 and 2.5 in an outpatient setting. So the criteria is already baseline, and this has been going on for years. So this isn't being thought of out of a box, and we're not reinventing a wheel. We're actually utilizing the wheel that now to be added into statute and in policy and in regulatory environments, so that we don't have to continue to deal with people saying, well, what is this? What is that? Well, what is this and what is that has existed for quite a while. We're pretty much playing catch up in a written form, right, to what really good centers have already been practicing. And insurance isn't going to approve somebody to be in your program if they don't meet the criteria within the ASAM variety. So this is already encompassing clinical and medical criteria. Secondly, right now, as far as not having housing, we're going through it all the time. For the clients who are in my program that are meeting criteria under medical assessment and clinical assessment for Suboxone use or Sublocade, getting them into a level 2 is sometimes nightmarish.
Yeah.
So whether you actually have a bed open or not, it doesn't serve any purpose if they're denying a segment of the population, which equals between 8 and 17% roughly, depending on what program you're looking at, that have clients that have met criteria to be on Suboxone or Sublocade. So if you take 100 individual beds in a level 4 treatment and you say, hey, 12 of these people are on Suboxone or Sublocade, and I tried to now graduate them out of IOP and then through OP and into a level 2, right? What we used to call halfway or sober homes, which are now recovery residences. And they say, no, sorry, can't do it. Well, why? Because I'm not going to allow somebody here on subs. You've just denied a bed. So you're already in effect denying a bed regardless of how many beds you think exist. And so this law is important. It's appropriate. It needs to be legislative. And there was a lot of work that was put into this. And I'm happy if people want to participate from other organizations and entities and environments in having these discussions. We're a very open book, far as people who run these treatment centers are. But this is a huge problem. And this is just simply buttressing an already existing fact.
Yeah, and I also kind of go back to what Jeff Lynn just said about the fact it already is required as far as providers are concerned. So, yeah, I'm again, want to hear from everybody. Dave Ehrenberg runs the ship here. But okay, Neil, you had your hand up as well. Neil? Neil still on? Because his hand was up. All
Maybe
right.
he's tired of arguing.
Okay. Well, Neil, chime in when when your computer comes back online. Or whatever. I hope you're here because I do want to get your input on the certified recovery residence administrator.
So
piece.
Susan and Dr. Moran have our hands
there
up.
he is. Yeah,
Okay.
Neil's there.
Okay.
Hey, I came back, but I didn't have my hand up. It was still up from previous
Oh,
questions.
it's not
Sorry.
from previous. Yeah, don't leave us here. We got to talk about CRRA.
Yeah, I was going to drop the bomb and run, but
Oh no. All right, Dr. Moran, you go ahead.
Just a practical question, Al. How will anyone confirm the number of days abstinence?
Well, we're not going there anymore. We're back to the original draft, which says you can't do it for that sole reason, sole basis. You know, if you have another basis, for example, Oxford House has a lot of bases because their normal protocol is they got to vote you in as a democratically run house, and they're all post, you know, mostly post treatment, other than maybe occasional, maybe outpatient. And that's level one. Okay, let's move on.
Okay.
Thank you all, by the way, very much. You really, really was a great discussion. Okay, and then 14, a local law, ordinance, or regulation may not regulate the duration or frequency of resident stay in a certified recovery residence in multifamily zoning districts. This paragraph does not apply to any local law, ordinance, etc., adopted before January 1st of 2024. You know, basically, you talk about the FHA and the ADA, it is a violation of federal law to treat recovery residences as some kind of board and care or an Airbnb. There's case law on that. Thank you, Jeff. I know you sent me some. It's, you know, just because people don't often litigate, I think that there'll be more litigation. And this, again, I got no pushback from this. Again, it's in multifamily zoning districts, but I got to tell you, I'm in my read of the case law is it might be illegal in a single family district as well. But let's do it here. But anyway, because your frequency of stay, short frequency of stay is more likely to be in a level 3 or a level 4 house, where treatment is for 30 days or 45 days or something of the like, as opposed to a 1 or 2, where the stay may be years. I mean, there may be some people who leave prematurely, but they don't come in with the idea that when treatment concludes, they're going to move on to someplace else. Dr. Moran, is your hand up from before, or is your hand up for this? Okay, anybody have anything to say about this one? Okay, let's move on. I'm gonna get you guys out of here early. Again, that arrested and is awaiting final disposition on line 135 and 6 is just basically conforming this to the provider statute regarding felony convictions or arrest. And we move on to, I believe this may be our last. Yep. Okay. If you recall last year, there was a level 4 provision that we were bandying about going up to 250 residents for 1 CRRA. We're bringing this back, but we've made some changes. So a certified, well, let me just, okay, notwithstanding subsection B, okay, which caps you at 100, 50 and 100 if you have permission from FAR. A level 4 only applies to level 4, certified recovery residence that meets the definition of community housing under 311.9 and is actively managed by a certified recovery residence administrator already approved for 100 residents under this section and is wholly owned and controlled by a license. So it's very specific to day or night with housing here. May actively manage up to 150. I can't imagine 250 in Florida. And in discussions, this is, you know, this is reasonable. 150 residents so long as a licensed service provider maintains a service provider personnel to patient ratio of 1:8 and maintains 24/7 is probably not good legislative speak, so it would be a 24-hour a day on-site supervision at the residence, which already is required, by the way, on level 4, 24-hour supervision with personnel to resident ratio of 1:10. So you're going to have house managers and the recovery residence administrator, which is more of the overseer of the program itself, is allowed in this one instance, one carve out, to go up to 150 residents max. And if for some reason that recovery residence administrator leaves that particular provider, they go back to 50 residents for any other service provider without being reapproved. And I put that, I believe we need to do that. It's not in this version, but as I was going through the statute, I think you go back to 50 residents unless you're reapproved by the credentialing entity for 100. Okay, makes sense to everybody. Neil, I wanted you to chime in on this because I know you were a critic of the 250. Does this seem reasonable to you based on the workforce?
Yeah, I mean, I wasn't keen on 250. So it needs, I need to understand it a little bit better, to be honest, because it just 250 just doesn't sound like 250 of anybody for one individual. Just to me, doesn't sound like that's best practice.
Right. So we've reduced
No, I
it to
agree.
150. Yeah.
Yeah, I
Okay.
agree.
I just want to make sure this, the FCB doesn't have a real issue with this. So thank you.
No, it's good.
And question, has there been any change in the workforce? Have more people gotten certified since, I believe the last time you were asked this question was during the last legislative session about a year ago, a little less, 8 months ago. So how's it going? Any movement on that front?
It hasn't been as steady. I mean, the whole workforce certification has been slower than normal, particularly with the addiction credentials, because I think you may recall that we did try to put a requirement in that individuals had to be certified years ago if they were going to deliver direct services. And we just got a lot of pushback. So technically in Florida, you don't have to be certified to deliver services. So with our certifications, like in child welfare, where we have very similar workforce issues, people have to be certified. And so those maintain. But in the addictions right now in behavioral health, they have definitely dropped off with the workforce shortage for sure.
Okay. All right.
We're still getting them in, but nothing like we have previously.
Well, hopefully,
before COVID.
Okay. Well, hopefully with the career path issues that are being addressed right now, to try to make it a career path as opposed to just a dead end job, basically, at minimum wage or slightly above. We'll be able to get more people interested in at least getting into the system and then keeping, advancing through it. So hopefully that
agreed.
Teresa, you have your hand up, please.
Thank you. Hi. Just a question, because earlier you mentioned increasing the capacity or oversight of, extending the time that a certified administrator.
You're talking about to where their certification is revoked or suspended at that part?
Well, you mentioned increasing the time that a recovery residence has in order to basically replace the administrator, correct?
Yes.
And then further on now, we're talking about increasing their capacity or oversight. So that means that more people will be potentially not managed for a longer or, for a longer period of time. What are the protections for that? Are we requiring the provider or the recovery residents to add additional behavioral health tech or someone else to take that place in the interim?
Well, I'm going to open that up for responses, but I'm going to spitball it right now and just say one of the things is it really is just applicable to level 4, where there already is oversight and management on a patient to staff ratio that's going to be lower than it would be in other programs. So the 90 days is so
Is there
that
even a need for a recovery administrator then? Recovery residence administrator?
that's that brings up a great question
No.
that goes back to 2016.
No, there's not. There's not.
We've had this
Yeah,
conversation
we have.
many times,
This
All right.
is
but the legislature felt there was.
Go ahead, Neil.
Got it. Thank you.
Neil reluctantly took on the task as a FCB to get into this space for recovery residence administrators. It really, the lifeblood of the recovery residence is the house manager. And the recovery residence administrator was never considered to be like a boots on the ground in a house of 10 people or 8 people. It just, the economics don't work unless they're patient brokering. And so we've talked about this, but yeah, you're right. It's from that perspective, no other state has a certified recovery residence administrator in their registration.
But Al, I still
certification
think
process.
I still think strongly that whoever's running a recovery residence, either the owner or someone, should sit for that exam in education, because what we learned on the other side is just because you open a treatment center doesn't mean you understand what a recovery residence is.
I think we have several people on this meeting that are CRRAs, and
Yeah.
I with his hand up here, Tori, I think is one of them.
Yeah.
That is true.
Yeah.
I am one. And I think the education is actually should be required. I think anybody who even opens up a level 4 to own one, honestly, should go through and I mean, I went to the addiction college as well to do my learning. I have no disagreement with that. And Teresa, the standards that this is being set for is specifically level 4. Right? This is specifically level 4, and the CRA in a level 4 is an administrator at their heart, right? And you have your behavioral health techs, you have your, as Al said, you could have what's called a recovery residence manager at the same time, but you're also integrated with your clinical staff, right? And your administrative staff and your case management staff and so forth. The only difference is clinical is not doing what's called permanent treatment at housing. You're having therapeutic environment established in your recovery residence, but it is an integrated model. So if a CRA, for instance, somewhat disappeared tomorrow, your operation should have already been set up to run and operate where everybody else, kind of like the Army, would have, the job above and below you, right? And that's how it's meant to be. The reason this bill is also, this part of the bill is look, there is a massive need that we're still not filling. And because the CRAs are limited by what before was an arbitrarily established number of 50 beds, and there was no scientific study for that number, it was just thrown out there. What's happening, unlike in the hospital field, unlike in, ALF field and so forth, where you're limited in the same exact way, we need more ability to expand bed capacity to meet a need. But the staffing part, 1 for 8, 1 for 10, is added into this in order to make sure that people aren't cutting corners on staffing. Personally, I've never had less than 3 for 1. And right now I believe I'm sitting at 2.01 for 1, 2.01 staff for 1, or 2.5 staff for every 1 resident. So the staffing requirements that were added are more than exist now at housing, which is 1 for 12 to go to 100. So, and it's 1 for 14, I believe, for 50. So everything that you're seeing is actually an increase from current standards now. So that's a higher bar of enlistment. And the 90 days was created to give a program that is running well, because FAR knows how to do its job, especially now, as Al mentioned, what's happened the last 6 months. FAR will know what program is running well or not. And that's where shall versus may was added. So that's what you're seeing now is the after effects of years of debate. And as everybody said, what is the CRA doing? Well, I think the education that Neil's put together is fabulous, and NAR did and FAR did. And that, I mean, we could talk about that too at another time, but I think that before you even get a license, they should have to take that test. That's my opinion. Someone's probably going to put me on their hit list now for saying that within the industry, but let's,
Maybe that's something to look to for the next session in 25, although we got a lot of stuff to look at. But this all this legislation that we've gone over, if you notice, is acutely limited to housing. It just happened this year that we had some tweaks, and we had then FAR's transition, as you just mentioned, Tori, is one of the reasons we've been able to do this and do it with the confidence that we're not going to create loopholes that are going to be exploited by bad actors. I think these are pretty tightly constructed. Again, we'll be discussing this when the session starts in our first meeting in January. Feel free, anybody, to email me, send me information if you have take umbrage with any of this. It's not set in stone, and God willing, we'll be able to get the staff from the Senate and the House to understand and be on board on these. Senator Harrell and Representative Caruso both vetted this, and they both are supportive. Obviously, they're sponsoring. Is there anything else anybody wants to bring up today? Got you out of here a little more than a half hour early. Longest meetings, I know. Anybody have anything? Well, thank you. And Teresa, welcome. It's really good to have you. Are we going to see you instead of Lee in January, or how's that working?
She works for the regional office. I work for Tallahassee, so I'll definitely try to join more of these. I was just made aware that they were still going on, so I'll definitely try to make it. And sorry if I brought up old wounds. I didn't mean to. I appreciate the history on it, but thank you.
No, we're going to be finished our 7th year in July, so and that was one of the first issues that came up is this CRRA concept, which we have, and we're not going to get rid of it, but it really is more, especially in level 4, it is more an administrative role. It's not hands-on. Level 2, yeah, be more hands-on with 50.
Hey, Al, I
yes.
know I don't have my hand up. It's Tori. I apologize, and I'm
That's
not going to
okay.
extend the meeting any further. Just to Teresa's point, Teresa, I think Al and I think everybody here would welcome your involvement in the sense of these meetings, and I'll volunteer Al to take your phone call at any time, because he's
I'll give you my cell, my work
Teresa,
cell.
you can call me too. I am counsel for FAR.
Yeah.
And yes, I do sue treatment centers, but I have other hats on, and we welcome this because we need as many people out there in all these different agencies to work together. So
100%.
it's really important to us. So I did. Even Tori, I agree with Tori sometimes, which is rare, but it's happened today twice.
Yes.
So he's
Well,
like on a FAR committee. Jeff is on a FAR committee. We got a lot of FAR people here, Heidi and Josh. So we want to be able to communicate because we do work, we're in parallel and similar universes.
Okay, let's say you have your hand up.
Oh, listen.
And Lissa does not have any connection with FAR.
That I do not, but I appreciate them all. Heidi's been doing some wonderful things. The DPAC meeting got moved from today till tomorrow morning. It can be accessed via Zoom, but it is, well, it's the statewide drug policy advisory council. It's Doug Simon and Ashley Moody's group. But they're going to be discussing on how to use the opioid abatement dollars, and similar to what you shared that John shared. It starts tomorrow morning at 8:30.
Okay. Oh, yeah. Thank you for bringing that up. I'm gonna be in the air, so I can't participate. But I know there's some criticism that there aren't more boots on the ground, and by boots on the ground I mean providers. I don't think that FAR is part of that meeting, which.
Correct. And we've been talking to Doug about it. There's not really parent representation. I mean, even Ariana's not on it, and that's really heavy law enforcement.
Yeah. So anyway, we don't have control over that, but I believe that people should make their voices heard about expanding the depth of knowledge in the field, you know, and have some boots on the ground that can contribute. But I'm also glad you brought that up, because John Hewlick had sent me the portals from the Attorney General's office, and we have the 18-year projected payout to every municipality that was joined in the lawsuit, and every county in Florida. So you can look up the portal and you can see what, you know, how much money Palm Beach County is going to get in this year and the next 18 years.
Yep.
And so if anybody needs the portal, please contact Mary Ann, and matter of fact, I'm going to just have her send it out to everybody.
I just put the link for tomorrow's meeting in the chat.
Oh, you have okay, you put the link in there? Good. So
It's 8:30 to 11:30 tomorrow morning.
Oh, but the portal, you didn't put the portal link in.
Not the portal, just the link for the meeting tomorrow.
Okay, and that's not the state dollars, that is the local dollars that are earmarked for. So it's not going to the managing entity, it's going directly to the local governments. Okay, and with that, I think that Jeff, you have the last word here, because your hand is up, but you're muted, buddy.
Hello, sir. Just for goods and welfare for the group, while we were in our meeting, I got a press release that more than 36 states and the District of Columbia on Tuesday hit Meta Platforms, Facebook, with lawsuits accusing the social media giant of designing and deploying harmful features on Instagram and Facebook that purposefully addict children and teens, and of routinely collecting data from children under 13 without consent. A bipartisan coalition of attorneys from all states, including Florida, have filed their own lawsuits in state and federal court, complaining that these systems intentionally were designed to addict children and have caused mental health issues that have yet to be determined. Wow. So I know we're an addiction group, but I know everyone here touches on the mental health side. So for whatever that's worth, that should be interesting conversation going forward.
Okay, thanks for that. And we'll see you on January 4th, I believe. It's a Tuesday, right?
Thursday.
It's a Thursday. Good. Okay. Thursday, January 4th. Anyway, thank you, everybody. Really great input. Thank you.